Good morning, everyone, and welcome to Mailman Center Grand Rounds. We are very thrilled to have Dr. Manny Jimenez joining us as our special guest. Before I go too much further, just to make it easier for everyone for accessibility, as I said, my name is Jeff Brosco, and I am a white male with brown hair and sort of brown eyes, at least what's left of my hair. If you happen to hear a dog barking in the background, it's because someone walked in and my dog got excited, so I apologize for that in advance. So as you know, we have special Mailman Center Grand Rounds each September and October, where we invite well-known guests that have a long research track record and make a huge difference in our community. We're very lucky today to have Dr. Manny Jimenez, who is an assistant professor of pediatrics and family medicine and community health at the Rutgers Robert Wood Johnson Medical School. He's also the director of developmental behavioral peds education there at the Boggs Center, and a developmental behavioral pediatrician at the Children's Specialized Hospital. Dr. Jimenez did his medical degree at the Rutgers Robert Wood Johnson Medical School in New Brunswick, where I wanted to mention he co-founded the Promise Clinic. It's a student-run continuity clinic that was developed in partnership with Elijah's Promise Soup Kitchen. And I mention that because we have a number of medical students who are part of our next gen curriculum. We're just starting on their clerkships this month, the last couple of weeks, and they are extraordinarily interested in community service and have a huge docs program we should tell you about sometime, Manny. After medical school, Dr. Jimenez went to do his pediatric residency at Children's National Medical Center in Washington, D.C., and then served as the Joseph B. Kennedy Foundation Public Policy Fellow. He worked with Senator Jeanne Shaheen, where he worked on health and disability issues during the health reform debate. He then went to my alma mater, University of Pennsylvania, where he did a combined fellowship in developmental behavioral peds at CHOP, along with being a Robert Wood Johnson Foundation clinical scholar. And he managed to earn a master's degree in health policy research. He's taken all that experience in education and turned it out into really wonderful work that focuses on promoting optimal developmental health for vulnerable children and making the health system more responsive to their needs. He uses quantitative, qualitative, community-based Pittsburgh research methods and asks really relevant policy questions that we can answer through research. And he also proposes and tries to test sustainable solutions to real-world problems. So Manny really takes his education and his experience and wants to make it work for children and policy. And he's been remarkably successful, so being so early in his career. He's already had a Robert Wood Johnson Harold Amos Medical Faculty Development Award and an American at the Academic Pediatric Association Commonwealth Fund Young Investigator Award. And his policy work has been in New Jersey, working with children and families, their department there to improve access to services for children at risk. He's been a physician champion for the New Jersey chapter of the AAP there, working on pediatric partnerships. And he's worked on the AAP's Bright Futures Early Expert Panel. So please join me in welcoming Dr. Manny Jimenez as he talks to us about the ways that pediatric primary care and child development work so well together. Dr. Jimenez.
Thank you so much, Dr. Brosco. And it's really, I'm so grateful to have the opportunity to be with you today. And so I'll just swap my screen here. And is that in presentation mode? Everyone see.
It looks like we can see your next slide too, so you might want to move to the slide presentation.
Yep. So I suppose this is like part of Grand Rounds now.
Yes, this is Grand Rounds in the modern age. We're surprised we can actually hear you. Amazing. The sound's working. There we go. Thanks.
All right, thank you so much, and thank you again. And so, and to start for accessibility, I have black hair, brown eyes, and the title of the presentation today is Promoting Optimal Developmental Health in Pediatric Primary Care. I have no relevant commercial relationships to disclose and won't reference any unlabeled or unapproved uses of products during the presentation. And so over the course of the next 50 minutes or so, I hope to be able to apply knowledge of child development to primary care developmental promotion and then to review evidence that supports current American Academy of Pediatric practice guidelines and policy statements. Most importantly, what I hope I can achieve is to really illustrate why developmental promotion, I think, is really central to our identity as pediatricians and pediatric healthcare professionals, and the real opportunity that we have to support optimal developmental health and equity. So I'll start with a case vignette. My work is driven by the patients I see. And this case is truly sort of an amalgamation of many of the early cases I was seeing when I first came to New Brunswick. And so Kevin's an 8-year-old boy presenting for an ADHD evaluation. His parents first became concerned with his learning and behavior last year when his teacher suggested he may need to be held back in 2nd grade. Now in 3rd grade, his academic performance has declined. Kevin struggles with reading. When asked to read out loud in class, his pace is slow. He makes several errors. He's unable to answer questions about the text that he just read. Lately, when he's called in class, Kevin tries to make the other kids laugh. When pressed, he refuses to participate. He appears distracted during in-class assignments and initiates conversations with his classmates during instruction. Kevin lives with his mother, father, and 2 younger sisters. His family emigrated to the US from Honduras before Kevin was born. Neither of his parents completed secondary school. His father works in construction and his mother works in a warehouse. Kevin's family mostly speaks Spanish at home, although he was exposed to English largely through media since his first year of life. He began shifting towards predominantly speaking English when he began preschool at age 4. Despite his current academic concerns, Kevin has not received additional academic support at this point, nor has the school initiated a child study team evaluation. And privately, a teacher's aide approached Kevin's mother. She suggested that Kevin appears to be showing signs of ADHD, and in her experience, medication can really help children like Kevin. And so, as I mentioned, this case was similar to ones I was seeing on a regular basis in my clinic. And it's no surprise, given that sitting here in New Brunswick, nearly 8 out of 10 3rd graders don't meet grade level reading standards. And that's the case in other large cities in New Jersey and in other large cities throughout the United States. And so what bothered me and what sort of drove me to sort of think more deeply about this is because there was more to the picture, and there were things that we could potentially do for kids like Kevin earlier on. And so I'll address 2 central questions during this talk. So first, why should pediatric healthcare professionals dedicate time to promoting optimal developmental health during their busy visits? And then the second is, how can pediatric healthcare professionals promote optimal development? And so really kind of the 2 central questions, why and then how. So starting with the why. So I'll begin with invoking kind of 6 key principles of language development. So children learn what they hear the most. Children learn words from things and events that interest them. Interactive and responsive rather than passive contexts promote language learning. Children learn words best from meaningful contexts. Children need to hear diverse words and language structures, and vocabulary and grammar development are reciprocal processes. And so importantly, these apply to whether you're learning 1 language, 2, or more. And so again, especially relevant for a case such as in our opening vignette. Importantly, inequities begin early. And so this is a chart that illustrates seminal work by 2 educators, Hart and Risley, in the 90s, where they went into children's homes and they counted the number of words that kids were exposed to. And they compared children from low income, middle income, and high income backgrounds. And what the chart illustrates is that kids who were coming from higher income backgrounds were exposed to many more words compared to children from low income backgrounds. And if you extrapolate that over the course of the first 5 years of a child's life, it becomes a difference of tens of millions of words that children are exposed to. And so this has been popularized as the 30 million word gap and sort of the lay audience. And so certainly, as in all science, right, there's limitations in the work. There's been work that's sort of been geared towards trying to better understand sort of the differences that we appreciate between kids from different backgrounds. But again, what I think we have to sort of acknowledge is, that, there are differences and that there are opportunities to really promote optimal development in this way. And so recognizing, coming back to sort of our 6 principles, right? Use and exposure are 2 key aspects of language development that we can support children. And so coming back, why should pediatric professionals care about this? And so school readiness truly is an upstream determinant of health. Early oral language skills strongly predict later academic achievement. And then school readiness in turn predicts academic achievement in 3rd grade and beyond, which is remarkably stable. It predicts key health indicators, health risk behaviors at age 17, and other more global markers of well-being, like college attendance, earnings, and retirement savings. And so pediatric professionals, as I mentioned, have a unique opportunity. And so I'll make the argument in sort of 3 cases. So first, we have near universal access to children. So there's been major policy efforts over the course of the last decades in terms of expanding public health insurance coverage through Medicaid and the Children's Health Insurance Program. And as a result, we've seen an expansion of health insurance coverage for children. And in fact, when you look, 95% of children have their required vaccines upon kindergarten entry. And granted, this was sort of pre-pandemic, and it sort of introduces a whole level of complexity. But we can just kind of hold this, like under typical circumstances, and perhaps even under these extreme circumstances, we have contact with children in healthcare settings, and it is an opportunity to support them. And then again, about 84% of children attend at least one well-child visit in the past year. So frequent, regular contact with children. And so this just illustrates the Bright Futures guidelines in terms of how many times we get to see kids. So Bright Futures recommends up to 15 visits in the first 5 years of a child's life. Relative to other professionals, there's few who have such, again, near universal access and regular access to kids. And then lastly, the parent-clinician relationship. So with the near universal access to children that we have, with the regular contact, we have an opportunity to really build trusted relationships. And certainly we can't take this for granted. And there's work that we need to do on our end to ensure that we build trust and that we leverage that opportunity. However, in our own work with families and work that others have done, families do seek advice from pediatric professionals regarding early childhood development and school readiness. And so from our perspective, it's important to be prepared. So in terms of framing my argument, then I'll say, people who are much more accomplished and smarter than me also think it's important. And so there's a series of guidelines and policy statements that really push this notion of developmental promotion, of early detection of developmental delays, of school readiness. So the American Academy of Pediatrics has released several guidelines, as well as policy statements, and as I mentioned before, Bright Futures. And invoking, one of the founders of our field, T. Barry Brazelton, field of developmental pediatrics. So I'll just quote something from one of the original versions of its beautiful textbook, Encounters with Children. So if the primary care professional can participate in the enormous richness of the child's and parents' development as his or her area to share with families, He or she will feel the excitement of the developing child and family. He or she can understand and participate in the emotional and cognitive development of the child. The professional will feel the rewards of a deepening relationship with the parent in his or her care. If the professional demonstrates a real understanding and gives a sense of caring for these aspects of the child's development, every parent will feel supported and cared for. And so, from my perspective, I mean, this is what we can aspire to. And the interactions that we have with families and the interactions that we have with children, it's really rekindling that sort of relationship that we have with families and with children and can support them for their well-being and health. So now moving to the how. How can we support children's development in primary care? And so again, I'll argue that there's actually strong evidence to support several things that we can do, or multiple things that we can do during our well child visits and while we're interacting with families to support optimal developmental health. First, revisiting our vignette. So at age 2, Kevin used 10 words in Spanish and no words in English. His mother expressed her concern to Kevin's pediatrician. Kevin's pediatrician reassured her that this was probably normal. He made a referral for a speech language evaluation just in case. When Kevin made it to the evaluation, the speech therapist determined that he was not eligible for therapy and encouraged his mother to stick to one language to avoid confusing him. And so too often I still hear this when I'm interacting with families. And so returning to sort of principles of language development. So this is a wonderful paper that Dr. Erica Hoff and her colleague published a few years ago about like what clinicians need to know about bilingual development. And so first, dual language input does not confuse children. But it's important to recognize that we can't just assume that a dual language learner is the same as a monolingual learner. And so learning 2 languages does in fact take longer than learning 1 language. But when we're considering a child's development and their developmental trajectory, it's important to consider the total vocabulary as opposed to just comparing 1 language to a monolingual child's language. Again, the quantity and quality of bilingual input in each language influences the rate of development. And key here, and sort of again, kind of closing out this segment of the vignette, immigrant parents should not be discouraged from speaking the heritage language, their native language, to their children for a variety of reasons, from the perspective of language development, but then also in terms of identity formation, social emotional connection, the advantages that bilingualism can confer to children later on. So it's critical, again, like our preparedness as healthcare professionals to be ready to support children like Kevin and their families. So intervention 1, I'm thinking in pediatric professional and the things we can do in pediatric healthcare settings. So surveillance, screening, and linking to resources. And I'll discuss especially why this is a process and doesn't occur in isolation. So first, coming back to sort of a few helpful definitions. So beginning with developmental surveillance. So surveillance is a flexible, longitudinal, continuous, and cumulative process whereby knowledgeable healthcare professionals identify children who may have developmental concerns. And so this is really envisioned as something that's going to occur at every well visit, where we're able to elicit and attend to parents' concerns, maintain thorough developmental histories, and importantly, putting these in the context of risk and protective factors. When we discuss developmental screening, it's not a substitute, it's really a supplement, right? So developmental screening is using a validated structured tool at designated intervals to help identify children with developmental delay. For the purposes of kind of this discussion, we're really talking about general developmental screening and then condition-specific screening. The American Pediatrics recommends that pediatricians conduct developmental surveillance at all well visits, and then general developmental screening at 9, 18, 24, 30 months, and autism-specific screening at the 18 and 24-month visits. One of my mentors, Paul Dworkin, always, I think, points out the importance of sort of thinking of this in sort of unity, right? So, oftentimes there's this temptation to sort of think it's either surveillance or it's screening. But really, when we're at our best is when we're doing it together, right? So when we're leveraging our relationship with families to be able to listen to their concerns and respond to them. And then using validated screening tools that have been used in populations, right? And that we have a sense of how they perform to be able to identify kids at risk. And when we engage in this kind of a system, we're truly in a position to identify kids who need more support. These are just some of the commonly used screening tools. And so, the Ages and Stages questionnaire has been around for quite some time and is very well validated and has been studied extensively, as has the PEDS. The survey of well-being of young children, is kind of the new kid on the block from a developmental screening perspective. But it's in the studies that have been conducted, it performs quite well, and it has two kind of key advantages from my perspective. One, it's in the public domain, right? So there's no concerns in terms of being able to upload this into that electronic medical record system. There's no licensing issues that you need to be concerned about. And another key advantage is the literacy burden for families. And so, whereas some of the other screening tools have, literacy demands in the 4th to 6th grade range. The SWIC is really written with short stems and has a literacy burden of around the 2nd to 3rd grade level. And the sensitivity and specificity perform similarly. A critical issue, again, coming back to sort of our vignette, is ensuring that we have accessible screening tools for families who do not speak the majority language. And so this is a great resource that my colleagues at Children's Hospital of Philadelphia, Kate Yoon and Marcia Gertis, produced a few years ago. That sort of walk through the process of translating tools that when there aren't available translations. So, the ones I listed previously, do have Spanish versions available that have been translated. But, like as a consumer of these tools, it's really important to kind of think about, how is it translated, right? The rigor of the process. Has it been culturally adapted, right? So like there's kind of key, especially, Kate often like raises the example of, and this came up with the SLIC when they were translating the version when, kids are coming over from places where it may not be cold, right? So buttoning a coat may not actually be applicable or may not be something that they've been exposed to before. And so we need to be in tune with those kind of examples that maybe we're using as to sort of assess, developmental concerns and recognize that exposure is not necessarily uniform. And then I'll just quickly touch on the evidence for developmental screening. So this is work by Dr. Jim Guevara at CHOP that I had the opportunity to participate in when I was a fellow at CHOP. So the TED study, or Translating Evidence-Based Developmental Screening in Primary Care, was really set up as a comparative effectiveness study of distinct approaches to developmental screening. And so there were 3 arms: surveillance alone, the second with developmental screening with office staff support to help them conduct the screening, and then a 3rd arm of developmental screening and surveillance without office staff support. And it was conducted in 4 urban pediatric practices with a very large sample size, over 2,000. And so this graph, I think, does a nice job of kind of summarizing the high-level findings, right? And so when pediatricians and the pediatric professionals in the office engaged in the process of surveillance and screening, we saw kids identified with developmental delays earlier compared to just surveillance alone. However, screening is only the first step. Identifying concerns is only a first step. And so this is work that we did in follow-up to understand of the kids that we were identifying with developmental delays through developmental surveillance and screening, how many kids were actually evaluated by the early intervention agency. And what we found was really eye-opening from my perspective. So only about a third of the kids who were identified with concerns ended up being evaluated for services. And so, and there were multiple drop-offs as the slide illustrates. So from identification of the concern to pediatric professionals making the decision to refer for services, and then even among the kids who were referred, being able to connect them to the early intervention agency. And so, this is, where I was sort of starting off in terms of advocating for thinking about this as truly a process and sort of a system of early identification and linkage to services. And so this was work that was done by the CHOP Policy Lab. Again, sort of thinking about how do we kind of build sort of a system for children in terms of kids who are at risk for developmental delay. And so it really goes from screening all the way through service receipt. And so thinking about each of these kind of processes as distinct steps: screening, early identification, referral for services, ensuring intake with the agency, ensuring an evaluation, and then ensuring service receipt. And each of these points truly is an opportunity for pediatric professionals and the medical home more generally to be able to support families in terms of making those links. And when we're thinking about linking families to supports, one key support, especially in the context of developmental screening, is Part C, early intervention services. And so the Part C program is the birth to 36 months. It's a federal program that's administered at the state level, a family-centered model based on children's specific developmental needs that includes a multidisciplinary evaluation and then working with the families to kind of tailor a support plan for those who are eligible. Now, it's important to recognize that although it's a federal program, it's administered at the state level. So there's going to be some variation across states in terms of eligibility. There are children who may be at risk for developmental delay who do not meet eligibility criteria. And so what do we do then? And so, this is where models like Help Me Grow and other sort of similar models like the Early Childhood Comprehensive Systems, Project Launch, other initiatives that really sort of focus on ensuring that we provide supports to kids tailored to their needs, right? And so not thinking of it as sort of a dichotomous, either you qualify for supports or you don't, but really ensuring that we kind of aspire to kind of a tiered model, right, where we're able to kind of provide support to kids. And so the Help Me Grow model is really, it's not a standalone program, but what it is a system that seeks to utilize and build on the strengths of the existing resources to develop and enhance a comprehensive approach to early childhood system building. And sort of the four pillars of the model are having centralized access point, outreach, data collection analysis, and then really working towards building partnerships with child healthcare professionals. And so this model was started by Dr. Dworkin in Connecticut and has now spread to over 20 states. And in fact, New Jersey is one of these states. And I'll talk a little bit more later on about some of the work that we've been doing in terms of thinking of how we integrate the work that we do in primary care to what's happening at the community and system level. So coming back to the vignette. So at age 5, Kevin saw his pediatrician for a school physical the summer before starting kindergarten. Although Kevin's family mostly speaks Spanish at home, his dominant language is now English, as we mentioned before. Last year, Kevin's mother did not receive much feedback from his preschool teacher, except that he was very kind to his classmates and his teacher, and his mom assumed that no news was good news. And so the clinician who had seen the latest surveillance and screening guidelines and the new emphasis on ensuring that school readiness is addressed in the 5-year visit, did sort of a brief assessment. So asked Kevin to write his name. When he did that, he just kind of scribbled on the piece of paper. When she showed Kevin letters, he didn't recognize any and did not show any awareness regarding what sound matches to what letter. She asked Kevin to count to 10, to count, and he gets to about 10. And the pediatrician is concerned about what she's seeing, but is really unsure what to do. And so she encourages Kevin's mom to talk with the kindergarten teacher early in the school year. So again, so many kids come in for those school physicals, and it's a real opportunity to be able to identify needs early, and to be able to kind of help interrupt trajectories where kids may not be on the optimal track. And too often it is an opportunity that we miss. And so, in addition to thinking about how, as pediatric professionals, we link to services or refer, there's also things that we can do actually in the office to support development when kids are actually with us. And so I'll talk a little bit about some strategies here. Again, in terms of activities that we can do with kids that can promote optimal development, shared reading is an important one. So it exposes children to more complex vocabulary and language structure, right? So coming back to sort of those key principles of language development, right? Grammar, vocabulary, sort of reciprocal processes, exposure to high quality language is key, and use of language is key to kind of helping promote language. So again, here shared reading is a great activity to be able to achieve those principles. And in fact, reading is associated with receptive and expressive language development or enhanced outcomes. Importantly, there's emerging evidence that it isn't just about words, it also is about the parent-child relationship. And so the opportunity for establishing joint attention around the book and to be able to kind of share an experience together, mechanistically makes sense that it can promote social emotional development. And there is, in fact, emerging evidence to suggest it. And some of the work that we've been doing, both my team as well as my colleague Alan Mendelson's team up at NYU, also sort of is showing how it's not just affecting the child, it's also potentially affecting the parent. And so we using data from a birth cohort, we found that reading in infancy was associated with reduced harsh discipline practices later on in the child's life. And Alan and his team have demonstrated associations between reading and other positive parenting interactions. Two visionary pediatricians sort of saw this back in the 80s. So Dr. Zuckerman and Dr. Robert Needleman at Boston Medical Center founded a program called Reach Out and Read, where, again, recognizing the near universal access to children, the frequent contact, they saw an opportunity to introduce shared reading as something that families could do together. And so it started very organically with giving out books to kids and families. And remarkably, putting my implementation science hat on, it's amazing how this has just grown. Now it's in over 6,000 clinics nationwide, serving nearly 5 million children. Really on the basis of, pediatric professionals seeing this as something that's important and, giving their time and volunteering to do it. In terms of things that we do in primary care, Reach on Read probably has one of the strongest evidence bases. So, there's now over a dozen studies that link Reach on Read to improved or enhanced shared reading frequency, enhanced language developmental outcomes. There's emerging evidence in the parent-clinician relationship that can be strengthened. But even the sort of the greatest and best interventions always have opportunities for innovation and for further growth. And so this is where a lot of our work has kind of focused on over the past 7 years. Latino families, although they're more likely to have heard the advice to read with their children, they're still less likely to do it. And even among families that have participated in more, or the children who participated in more, language scores still fall below the overall population. And so, about a standard deviation, which is sizable. And children continue to be at elevated risk for reading problems prior to kindergarten entry. And so this has, from my perspective, everything to do with the magnitude of the existing inequities, and really is a call for, again, to think about how we can sort of amplify and intensify these interventions that we have, as well, and further support families. And so, over the course of the past 7 years, we've been engaging with Latino families here in New Brunswick and sort of the surrounding area, community leaders, to really think about how we can understand shared reading in the context of parenting more broadly, and then how we can sort of enhance existing interventions like Reach on Read to better support families. And just quickly, again, recognizing the evidence base for Reach on Read and how Reach on Read has really been demonstrated as an evidence-based practice, and really truly a model for literacy promotion and developmental promotion in primary care settings. But I think, as thinking about kind of where sort of the knowledge gaps are and where research needs to go. Again, thinking about kind of what are the, how we sort of describe the components of literacy promotion more consistently. Because when we do that, then we'll be able to kind of better understand what are kind of active ingredients, and really thinking about, the mechanisms of action that sort of underlie these interventions. Which can sort of help guide us in terms of supporting families. And then I'll speak now to a couple of the modifications and enhancements that we've been working towards in terms of amplifying the literacy promotion message in primary care, with a particular focus on Latino dual language learners. With support from the Harold Amos program, the first study that we conducted was a mixed method study where we engaged community leaders and parents to, again, understand shared reading in the context of daily parenting, and think about strategies that we could leverage to be able to amplify the literacy promotion message. And so recognizing that families, that were really the ubiquity of kind of technology and text messages and smartphones, we decided, and hearing from families that, reading was something that they prioritized, but was something that they kind of would benefit from reminders and messages. We developed a text messaging program to remind and provide motivational messages for families after they've left the office. And so in collaboration with families and community leaders, we developed these text messages, which you can see, as well as a video with just an absolutely adorable little guy who volunteered for our video series. And so we conducted a randomized control trial to compare the standard version of Reach on Read compared to this enhanced version, which we developed using text messages. And so what we found, and what this chart illustrates, is that, at the end of 6 months, families who had received additional text messages read on average about 2 more times per week compared to families in the standard arm who read 1 more time per week. And so a difference, although, and again, thinking from an early childhood perspective, small differences in early on may have downstream effects later. However, it also kind of made us think about what were the other things that we might be able to do to even enhance this further. This slide just provides a little bit more data in terms of what we found comparing our enhanced reach out and read to the standard version. And so again, these are Cohen D effect sizes. Looking at the home literacy environment, we found a difference of about 0.3. And so a small effect. So using mixed methods, we then went back to interview the families who we participated in our study to understand, why it worked or why it didn't, and what we could do differently in terms of making it more effective. And so we engaged in a series of in-depth interviews with families, and I'll highlight 2 key themes that have now driven our subsequent work and our ongoing work currently. So the first theme, the first remaining barrier, was that the stressors related to poverty took precedence over parent literacy activities, right? And so, this quote from one of our participants. So sometimes, I'm weak, I'm homeless, I have a lot of things going on, like a lot. So sometimes even if I want to, either I'm not in the mood because either I'm depressed or I get it's too much right now going on. And so again, thinking about how do we kind of support families addressing their kind of basic needs so that activities like shared reading and activities like conversation, turn taking are activities that we can support. And then another key barrier that we identified from families was, the parents themselves felt that their literacy skills and limited English proficiency prevented them from engaging in shared reading. And so here's a quote from one of the parents. "Well, I read him the little I know that I know because I don't know how to read well." And so from this perspective, it really kind of made us think about how do we leverage our opportunity to do more capacity and skill building. And so I'll talk about 2 ongoing studies now that have focused in on these 2 barriers. So with the first one, again, it pushed us to think about, like recognizing, as a pediatrician, right, ecological systems comes naturally, right? The child is nested within the family, nested within the community, nested within society. And so thinking of like pediatric primary care as a key place where we can support kids, what else is going on in the community that we might be able to partner with in order to address the material needs. And so here we come back to the Help Me Grow model, which here in New Jersey is operationalized as central intake. So we're in the process of now, we're in year 2 of a 5-year grant supported by NICHD to compare 3 distinct approaches to literacy promotion. So one, which uses the standard reach out and read model. The second, which uses reach out and read plus text messages. The third, which integrates literacy promotion efforts in primary care with the work that's happening through Help Me Grow here in New Jersey. And so families in this arm are linked directly to central intake upon completing the visit to have a intake evaluation to see what supports they could benefit from. And so we're following kids in these 3 arms for 18 months, assessing parenting behaviors as well as language and social emotional development. And again, central intake is based on the National Help Me Grow model. It's available in all 21 counties here in New Jersey. And what it does is it really creates a single access point for supports that can ameliorate the stresses related to poverty. So enhancing access to supports like WIC, SNAP. It provides case management to help kind of close the loop on these referrals. And there's also a developmental specialist on staff who actually then encourages other developmental promotion activities as well. Coming back to the second barrier, in terms of limited literacy and English proficiency functioning as a barrier from families' perspectives. We had this great opportunity to partner with a literacy expert in the Graduate School of Education here at Rutgers, as well as a linguist who specializes in second language acquisition and biliteracy development, to develop a family literacy program, which is geared towards kids who are entering kindergarten. So Latino dual language learners who are transitioning into kindergarten. And what we do is we use anticipatory guidance that's part of the 5-year visit. So which in itself is inherently important to school readiness. So nutrition, physical activity, sleep, social emotional development. And we use those topics to introduce basic foundational literacy and language skills to the kids and their families, and to provide sort of hands-on support to families in supporting those activities. Both one, by helping them to identify the things that they're already doing, so building on strengths. And so, which, these kind of health themes just have literacy promoting activities embedded in them, right? Things that we don't necessarily appreciate offhand, just looking at a nutrition label, counting beats while we're dancing. These are all things that we can do to kind of support basic academic readiness skills, and in a fun way with families. And so, and another sort of key goal is to ensure that we're promoting proficiency in English and Spanish for kids who are bilingual in English and Spanish. And so we partner with a local charter school here in New Brunswick, the Greater Brunswick Charter School, which is a dual language program, and their kindergarten teachers, with our manual, provide the workshops to parents and children. Again, empowering families to participate in these activities. And so we've conducted 3 successful pilots over the past 3 summers, and now actually through the Agency for Healthcare Research and Quality are now going to conduct a 5-year large-scale evaluation of the program. So I'll come back to sort of the vignette in closing. Returning to Kevin's story, I think a series of what ifs is, important to kind of consider, right? So what if Kevin's medical home had implemented evidence-based interventions to promote optimal developmental health with high fidelity? What if Kevin's primary care professional had listened to the mother's concerns and connected him with a prepared professional who could support his bilingual development? And then, the one that's most haunting for me, and the one I think about every time I step into the office, is what if Kevin came in today? Express my gratitude to all the collaborators and faculty staff who really make this work possible. Funders, the Robert Johnson Foundation Harold Amos program, and their ongoing support from NICHD and ARC, as well as the Rutgers Community Health Foundation and Global Health Seed Grant. So thank you.
Thanks so much, Dr. Jimenez. When you come in person, if you were here in person, you'd be hearing a lot of people clapping and making lots of noise. Everything you said, I think, is really consistent with a lot of the work that we're all doing here. And I don't know if you had a chance to see what was happening in the chat while you were speaking, but it was a nice discussion about bilingual education. And you're in some sense preaching to the choir here. So we're on your side. I know folks probably have some questions. I just want to start off with one as others are kind of gathering their questions, and that is, one of the things that we've talked about in terms of developmental screening is, does it make perfect sense to wait till a child's 2 years old and behind on language to refer to early intervention? There are things like, and there are things like the number of children's books in the home. If it's fewer than 10, that's a pretty good predictor that that child is not going to have language development like we expect. So could we even be screening for other things at the 2-month visit and 4-month visit that might get us even further ahead of the curve? I just wondered if you have any thoughts about that.
Yeah, it's such a great question. And again, it's sort of, I think it is kind of the wisdom of like kind of those who put together the policy statement to really think of this as kind of a system of surveillance and screening, right? And like if we are engaging in that process of surveillance, there's just an incredible opportunity to be able to kind of attend to sort of the risk factors that we might see, the strengths as well, and how to build on those strengths. And so like we've been doing some work also, which I didn't mention here, with the Reach on Read National Center around thinking about like things like early relational health and the first few visits, like in the newborn, and the second the 6-week visit, and sort of those early visits before the 6 months. Again, to like to both support the parent-child relationship, but then also to kind of think about, can we link families to resources and services? And I think this kind of also comes back to kind of thinking of things in like sort of a tiered model, right? So if we think of it dichotomously as like you're eligible for early intervention or you're not, we miss too many kids when there's so many other forms of early intervention, whether it's high quality childcare, other sort of parenting programs, which again, we can work collaboratively with, so.
Great. I noticed that our Dr. Flores and Dr. Coffey are chairs of peds and psychiatry are the first two up. Glenn, do you want to start?
Sure. So first of all, Manny, thank you for your wonderful work in this space. There's not enough research going on, and you certainly are a pioneer. So we're grateful for that. Just one comment and one question. So I just want to unequivocally get it out there because I've looked into this on a number of occasions. So raising children bilingually does not cause confusion, nor does it cause developmental delay. And it's interesting, historically, for decades, people said it caused both. And then when people actually did research, they found the opposite, that it didn't impact either of those. In fact, there's some really interesting studies that raising children bilingually actually improves their executive functioning. They're better than monolingual children, although I've noticed there are a few papers now shedding some controversy on that finding, but I just think it's interesting. There are actually advantages, which many of us see anecdotally. So just want to underscore that point when we talk to our parents about the advantages of raising children bilingually. And then the question relates to a number of years ago, my team and I analyzed some national data and found that after you adjust for everything, Latino households are much less likely to read to their children regularly. They're most likely to never read to their children, and they have substantially fewer children's books in their households. And so I wanted to get your thoughts about how we level the playing field, because that's an immediate disadvantage, regardless of how much you promote Reach Out and Read.
Yeah, thank you so much, Dr. Flores. Just to kind of amplify the first comment, again, it truly, so in no, bilingualism in no way, the evidence just does not support any sort of confusion, any sort of disadvantage. And in fact, to your point, it really, what it does is, there are advantages, like both kind of in the immediate in terms of cognitive flexibility and those other sort of, but then also like, thinking from terms of the global economy and thinking about, the economic opportunities that children can have if they are bilingual. And so, gosh, I think we all need to shout it from the rooftops, because unfortunately, many of these kind of myths still persist. And so in full disclosure, Dr. Flores, I actually cite your paper quite frequently, in making the case for why we need to think about, or why we need to innovate, and why we need to, even the intervention like Reach Out and Read, which again is, one of the best we have, we still need to think about how we can do better and how we can support families even more. And so, I think a couple of thoughts. So I think one, ensuring high fidelity implementation of a program like Reach Out and Read, and ensuring that's culturally responsive to families is critical, right? And so it's one sort of, kind of fastball right down the plate that we have for families right away. But then like there's these other opportunities to really be able to partner with what's going on in the community as well. And so, like both from the perspective of linking to like, again, high quality childcare, right? Early Head Start. But then there's other programs, like again, through Help Me Grow, or, analogous programs, like Books, Balls, and Toys, right? Where they actually go out into the community and they do similar activities. Dolly Parton's Imagination Library, which is another example of a program which can enrich the home literacy environment. But again, we also need to think about, like, what kind of books are we also giving, right? Like, ensuring that like we are providing books in Spanish or in the language that's that the family uses. And so a lot of opportunities and a lot of work yet to be done.
Yeah, and I'm glad you brought up Imagination Library because it's an amazing program. I'd love to see it sort of linked together, the Reach Out and Read. So for those of you not familiar with it, Dolly Parton came up with this program where basically a kid at birth gets a book sent to their home every month for the first 3 years, and talk about a way to eliminate that disparity of having fewer children's books at home. The problem is that she was able to get it done in Tennessee, but we haven't seen it statewide in other states, and there are sort of selected cities who do it, but it might be something for us to tackle here, not only in Miami-Dade, but Florida wide as well.
So as we said, we only have about 4 minutes left, but as we segue to Dr. Coffey, the Children's Trust is doing this in Miami. So we're ahead of the curve on that. Dr. Coffey.
I want to thank you very much, Dr. Menace, for a very interesting talk. And wearing my child and adolescent psychiatrist hat, I wondered about the role of social and emotional factors in children's ability to learn to read, and particular screening in the early years of life. I know you do, as pediatricians, screening for autism spectrum disorder, but is there any kind of consistent early in life, as opposed to later in life, screening for these kind of conditions?
Yeah, thank you so much for that question, because it's a really important one. And I think kind of a gap right now in terms of what we're doing from a developmental screening perspective. So the guidelines currently really focus on the 0 to 3 population. And there's been kind of a renewed, like in this last iteration of the developmental surveillance and screening guidelines, there was more sort of description of, or sort of thought applied towards the 4 and 5 year visits, which, are the kind of a key opportunity to be able to sort of identify kids who may be showing, delays in social emotional development, where there may be sort of attention concerns emerging. And so this again is like where it's both sort of a advocacy question as well as sort of a practice question, right? Because when we think about the evidence-based interventions that we have to support young children, preschoolers who have who are demonstrating concerns around attention development or social emotional development, it's the high quality parent-child programs that are kind of the best we have, and yet those are so hard to find. For any child, but compounding, other sort of, if there is, if the family does not use English as their preferred language, if the child does not have private insurance, it just creates even greater access for kids, greatest access challenges for kids, and so. There's a lot of work that we need to do in terms of trying to think about how we make these programs more accessible. Here, I'll just also highlight some of the work that my colleague, Dr. Alan Mendelson is doing up at NYU, and similar programs kind of that have kind of sprung up. The Video Interaction Project, in fact, is kind of designed as a universal program where staff coaches families on sort of positive parenting interactions, shared reading, and in fact, where they see the biggest effect sizes are in social emotional development. And so, I think there's real opportunities there.
So I noticed that it is 9 o'clock, so some folks are going to have to drop off, but I want to make sure we get to Dr. Armstrong and Dr. Delamater's questions. So Danny is our director of the Mailman Center. Danny, you have a question?
Yeah, Manny, excellent talk. And I'm going to push things just a little bit on you to think about, insurance prefers that we write a prescription. Reach Out and Read worked beautifully because people were very happy to give books. And so the supply and the time in the office to be able to say, here's a book to take home to read to your child, really made that a scalable program. But when I looked at your last slide, 8 sessions with the developmental specialists, the world is littered with programs that have shown to be effective that are on the dinosaur graveyard because they never got to scale. Do you have any thoughts about how you take what are these very good and really engaging interventions that require labor that isn't paid for, and how do we move that to a policy level that brings it to scale where it actually has widespread benefit?
Thank you so much, Dr. Armstrong. I mean, it is like, you know,
There's not an answer to that.
it is like the, you know, trillion or whatever the dollar question. But, you know, I think this is like kind of where it's so critical to kind of bring sort of the dissemination and implementation sort of science to early childhood interventions. You know, we talk about this a lot, like with regards to Reach On Read. You know, it's not like your typical sort of off the shelf, like kind of like, you know, theory based, you know, like NIH funded kind of intervention that, you know, had sort of a clear kind of theoretical model at the front. This like rose organically, and then it spread like wildfire, to your point. And so I think that's absolutely right. And so, you know, I think these are the answers that are the questions that we need to be asking, and then, you know, like working towards the answers. I mean, so certainly building on, you know, existing programs, again, like Help Me Grow, which has kind of been able to sort of also spread and, you know, take advantage of the resources that are already invested in the developmental specialists who are sort of already, you know, engaged and part of that program, and thinking about how we might be able to sort of leverage those kind of partnerships in order to be able to provide, you know, programs like the family wellness program that we're working on, or, you know, like the VIP model, or, you know, insert sort of evidence-based intervention there. But it's a lot of work. And I think, you know, it's kind of what gets me excited.
Thank you.
And Dr. Delameter is our division director for pediatric psychology. Yes, Alan.
Thanks so much, Devin. And thank you, Dr. Jimenez. Terrific talk. And I think you made a great case for the patient-centered medical home that really attends to social determinants, as well as developmental progress, well-being, literacy, all that. And I thought you made such an important point about the study that looked at better outcomes in practices where there was support, rather than not having support, the physician on his own, or no screening and surveillance at all. So given that, I mean, how do you see, and my question really builds on what Danny was just saying, the future of pediatric primary care, you know, in terms of even greater behavioral health care integration, and what do you think the funding models will be to really be able to achieve that?
Yeah, so it's such a nice dovetail in terms of Dr. Armstrong's question. And I think like, so, you know, I'll do my best to kind of invoke again, Dr. Paul Dworkin here. You know, so Dr. Dworkin always kind of emphasizes the importance of sort of systems thinking. And so, you know, like, how do we kind of position, you know, the efforts that are happening, you know, and you know, centrally to my talk, you know, like, how do we sort of place what's happening in the pediatric primary care in sort of the larger system. And so, you know, I do think like this is where, like, you know, like attention to models like Help Me Grow and models like ECCS might provide the opportunity to be able to achieve some of the scale and the work that's necessary. So it's a partial answer to a really important question.
Great. Well, thanks again, Manny. It's been wonderful to hear about your research and in the context of stuff that is really important to all the folks on this Zoom. So we look forward to having you come visit us in person so we can get a chance to meet with you and talk with you some more. We're going to end now. And so everyone join me in thanking Dr. Jimenez for coming through Zoom to speak to us, and we'll talk again. Take care, everyone. Have a great day.
Thank you again so much for the opportunity.
Bye-bye.